I wanted to start, and it's a lot of observation. I wanted to start with two words that were used by Dr. Marshall. Number one, 6 weeks, 7 weeks versus 20 years. It's a lot of experience. Second is the observation that most of the residents, fellows, they are sitting in the back. And I remember being an educator in Baylor and using all this sophistication, using all those mutations and how those mutation potentials were initiated. It was my passion, but I noticed residents that were backing up. They were getting far away from me. And with time, with feedback, I understood that I need to attract them to work with me. I had 0, and then I end with 10 of them working in the projects that we are going to be seeing right now. So when I was working toward creating the presentation for you guys, I had to change a little bit the name of the presentation. It was originally called the Acute Myelogenous Leukemia Genome, How to Treat. And then I decided to introduce a little concept, how to make it practical and easy for people to understand, because the easier it becomes, the more people we're going to be orbiting around hematologic malignancy. We will be able to launch a lot of ideas that we have from the past 10 years. And I wanted to go through few objectives. Go with me. Let's try to understand the important mechanisms that initiate acute myelogenous leukemia. Let's try to integrate with the notion that we're going to acquire today, commonly reported AML sequencing data, into potential disease initiating mechanisms. And then at the very end, we're going to try to understand how these mutations integrate, facilitate incorporation of risk-adapted therapy, including cellular therapy. So 3 objectives. In order to fulfill those objectives, then we're going to divide the presentation in 2 big domains. The very first domain is our investigation, our research on leukemogenesis, and then we're going to concentrate at the very end on a therapeutic window. So what are the knowns and unknowns of leukemogenesis? We are going to touch base in cell intrinsic processes that are important for everybody to understand, especially in a hemopoietic malignancy unit, germline predisposition, and the interaction with somatic events. And then we are going to bring to the table new insights into cell extrinsic processes that might expand, create dominance of these clones. The therapeutic window is going to be based on what are the changes that we have for a list of genes that we normally use to treat leukemia that I normally tell my residents and fellows, you are not going to remember all of them. You can take the list of those genes from your packet and remind yourself, because it's the Bible. Many leukemia treating physicians tell me, Gustavo, don't use that word, Bible. I do believe it's the word Bible. There are some caveats, and we are coming to them. Sorry. All right, let's go to the knowns and unknowns of leukemogenesis. So this is a publication that is pivotal in the work clonal hematopoiesis. It was in 2014, followed by this editorial. Let's read it. Clones of words, the emergence of neoplastic blood cell clones with aging. So here we can extract 2 main ideas. Number one is that these clones can pre-exist. They can precede the initiation of leukemia or hematologic malignancy for years before. So the second piece that we can extract from this editorial is that for whatever reason, aging and all the inflammation that is initiated by aging might contribute to Darwinian forces to create a clonality that is dominant. This is the preceding event. Keep this in mind, because the knowns is that human hematopoiesis remain proficient through life, but is dramatically challenged by age. These mutations that can be initiated in the hematopoietic stem compartment, they increase the fitness of the hematopoietic stem cell and progenitor. And when the allele frequency achieve a threshold of 2%, we call that clonal hematopoiesis. You can see to the right how these mutations can increase with age, becoming very dominant as we achieve 85, 90 years. Almost in every single individual will have clonal hematopoiesis. I want to remind you, these mutations, they have a intrinsic risk to initiate hematopoietic malignancies in 0.5 and 1% of the population per year. But the rest of the attribution of risk and comorbid condition is a stroke, heart attacks, dementia, many diseases that we face in our regular clinics and wards. So clonal hematopoiesis affect a group of mutations that are normally seen in acute myelogenous leukemia. I want to show you very quick 3 mutations that hematologists we need to remember: TEC2, DNMT3A, and AXSL1. You can see how dominant those mutations might be. So a few items that we need to remember for the presentation is the concept of clonal hematopoiesis. Remember, an allele frequency, this is going to happen. If you are an oncologist and you're treating colon cancer, breast cancer, and suddenly you are doing liquid biopsy from that patient and you find this myeloid specific mutation at 2% frequency, that patient has clonal hematopoiesis. So remember that term. The second is that this mutation, I already mentioned, increase the fitness of the cell that harbor the mutation. We're going to call that fitness growth. And we have brought to the table a concept that Darwinian forces are needed for this clone to be selected negatively, positively, or neutral. So the very last concept is the concept of orthogonality. You might remember these patients, once they have detectable mutations in myeloid-specific genes, you can repeat sequentially those testing, and you can see how those allele frequencies might expand over time. So that will give you the sense that you have a phase that is extremely objective for determination of orthogonality, but you can do simulations, and the simulation permit to create a very good sense when those mutations were initiated. For many mutations, it can happen 3 weeks post-conception, intrauterus. And then we had to think again, Darwin principle. What are making those mutations potentially to expand into hematologic malignancies? So here we have the work from the UK Biobank, and you can see sequential testing for 385 patients permitted orthogonality, right? This is the objective fact, the objective piece of the work. And then you have simulation, Bayesian simulation, determining that for those splicing events, the mutation can occur between 10 and 20 years. For other mutations, more specifically U2F1 splicing event, it can happen 40, 50 years of age. It tells you that potentially human beings, we are aging in a very different way. We are going to talk about that. So recently in ASH, it was published that TEC2, a very common clonal hematopoiesis mutation, is not the reason for inflammation during aging. It's the AML ecosystem. It's very interesting because the cells that are unmutated, not mutated, unmutated, are responsible for all the inflammation that we see as we age. This is extremely important. How to combat, how to abrogate this. So it comes to the complexity of the European Leukemia Network. As you can see, many mutations that I know begging you to remember, but you can keep this table in the pocket and we can be reminded, what are they? As you can see, many mutations. We are not going to go through them right now, but I want to show you 3 boxes. Favorable, people get treated only with chemotherapy. Intermediate, most of the time chemotherapy followed by allotransplantation. Adverse, everybody get chemotherapy and allotransplant. What I want to show you to the left is the estimated speed of clonal growth. For patients with P53, let's say you have a patient with colon cancer, breast cancer, lung cancer, and you detect that the MCV is 110, is increased. You have an RDW, very easy to look, high, and the patient have a history of smoking. It's very likely that a patient have a P53 shift. The patient is subjected to chemotherapy and you are inducing, again, principles of Darwin. The clone is going to be selected toward myeloid therapy-related myeloid neoplasia. So for P53, without chemotherapy, you can see the phase and the pace by, we think it grows 5% per year for a splicing event that you will see repeatedly, 10% SF3B1, 15% SRF2, and then the very bad one splicing event U2BF1, 20% per year. It means latency to leukemia might be differentially expressed by the proliferation efficiency of those clones. Then in order to understand a little bit how these mutations are initiated, I want to systematically divide processes that might be happening inside the cell and processes that might be happening outside the cell. Then we're going to touch base on germline predisposition. It's a very known process. SNP, right? Very well-known processes. Ethnic effect, this is less well characterized, but we are going to touch base on this. And then from the cell extrinsic standpoint, we are going to touch base on a composite inflammatory risk factors like aging, smoking, etc. So let's concentrate a little bit on this case. It's a 32 years old female. She was admitted with leukocytosis, and I want you to concentrate that she was diagnosed with acute myeloid leukemia. We did a pedigree, and you can see in the pedigree how the mother had low platelet, and aunt that she was diagnosed with acute myeloid leukemia, and then subsequently gathering information, the sister was diagnosed with some form of autoimmune bone marrow failure aplastic anemia. It rings the bell that potentially a germline predisposition might be sitting, explaining the initiation of leukemia. So somatically and germline a RANKS1 mutation was detected, suggesting that this patient and the family, the entire family, harbor a RANKS1 thrombocytopenic familial disorder that predisposed to AML conversion in 35% of the patients. This is extremely important. You can see the megakaryocytes, they have a prototypic and very classical distribution that is normally seen in these conditions. So I don't want you to remember exactly every single gene that is in this presentation from Dr. Lucy Gooley from University of Chicago. But I want you to remember that there are some genes that predispose to myeloid malignancy, lymphoid malignancy, immunodeficiency, overall risk for hematopoietic malignancies, and then risk for hemopoietic and non-hemopoietic malignancy. If you can remember at least this section, it will be extremely important. This is important for congenital neutropenia, AML risk, DDX41, very long latency for initiation of AML MDS, and then trisomy 21, important for Down syndrome, TEC2, RANKS1, as we touch base. Then the rest of the genes we can certainly review. They are very important customized arrays that we normally can use in the clinic, and it's important for a few items. The first item is that from the point of view, phenotypic point of view, the age of initiation of myelodysplastic syndrome might be a proxy for the type of genetic defect that the patient might harbor. Let's say Mirage syndrome normally happens 0 to 5 years of age, and then you can see how progressive increasing age might cluster patients with GARA2 deficiency, monocytopenia, and propensity for AML, MDS, then Fanconi anemia, sitting around this age, and this keratosis congenita. This is a big gap for understanding whether or not age is dictating phenotype for initiation of the diseases. And then I mentioned before DDX41 that is normally seen with initiation of acute myeloid leukemia MDS after age 60. This is extremely important. So in summary, germline predisposition should be investigated as a syndromic if you can cluster symptoms and signs. Let's say Fanconi anemia, normally the patient will develop bone marrow failure, but they can have high incidence of squamous cell carcinoma in the tongue, rectal area. You can suspect that this keratosis congenita, yellow nail, COPD, liver failure, and MDS, bone marrow failure. That will be syndromic, and some cases will be non-syndromic. Let's be very careful. It can happen. Long latency may occur in some pathogenic variants like DDX41. You remember, these leukemias can be initiated at age 16 and older. Identification of pathogenic germline variant, it will be much better for you to select what is the donor. In case that the patient requires a bone marrow transplantation, you might give the same mutation if the transplant is coming from a sister or brother, okay? This is extremely important. Then continue a SNP array. SNPs are predispositions that can be inherited through parents, is parental. You can see most recently the 5q15 predisposition for third right? It predisposes to clonal hematopoiesis. It leads to longer leukocyte telomere length, and this is associated with a high risk of clonal hematopoiesis. Another important recent discovery is the 14q382. It can predispose to clonal hematopoiesis driven by TEC2 or the NMT3A, depending on the allele that is mutated. So this is extremely important. Again, if you have a TEC2, you are going to initiate clonal hematopoiesis by age 50, 60, but if you have the NMT3A, you can initiate clonal hematopoiesis by age 20 to 30. Again, it's telling me that potentially human beings, they are aging in a very different way. Within this susceptibility region exists the TCL1A, right? When you do conditional depletion of the gene, you can see how hematopoietic stem cells, they expand dramatically, progenitors expand dramatically with a preceding event for hematopoietic malignancies. Then we're going to move a little bit into the work that we have done over the past 10 years. I want to mention that racial disparity might account for differential outcomes in AML, but let's try to create a foundation for this. Remember, African American, Hispanic, Latino AML patients are diagnosed at younger age. However, even though they present with favorable karyotype, African American will do worse. This is important. In the case of B-cell Philadelphia-like B-cell Philadelphia-like disease, 3 genes and GWAS pointing that some SNP might be important to create very aggressive leukemias. Indeed, all those patients that are indigenous American with American ancestry, they might develop extremely aggressive form of B-cell Philadelphia positive leukemia, very difficult to treat, primary refractory have been described. For non-Hispanic African-American patients with detectable clonal hematopoiesis, usually the outcome for acute myelogenous leukemia is extremely bad. With that in mind, we wonder if our patient treated in the Baylor institution, as you can see here, a total of 22 African-American patients, they exhibited an overall survival 162 days versus a cohort of patients who were no African-Americans, a survival of 709, 700 days, 709 days. You can see that this was statistically significant after adjusting for multiple factors. You can see that the presence of canonical adverse mutation and being African-American synergized to induce such an inferior outcome. With those factors in mind, we had 2 more steps to understand potentially why African-Americans were doing so bad. Then in order to estimate whether or not those mutations in African-Americans that represented only 12.4% of our population expressed differentially the frequency for the mutation, we compare against the cosmic database, which is mostly white population, against all the frequencies that you can see to the right for myeloid-specific mutation. You can see the cosmic database is adequate and it permits adjustment of frequencies against validation databases. The second piece is why our patients, African Americans, they have highly disorganized metaphases, meaning the chromosomes were extremely disorganized. With my student, we sat and we counted every single chromosomic anomaly and created a continuous variable. It goes from 1 to 27. You can imagine as the cell accumulate chromosomic anomalies, the degree of aneuploidy and chromosomic anomalies were higher. It permitted for some association. Then in conclusion, you can see that the distribution of the ELN 2017 molecular defects favor the patient African American. They have an excess in RANS1 mutation, which is an adverse mutation. And then we start observing very small but frequent mutations in DNA repair mechanisms enzymes, including CAX1. This is only for African American. There was a trend to have numeric chromosomic anomaly higher in African American, as you can see in the second line. Then the third line tells you that as age progresses, as we get older, the numeric chromosomic anomalies and the number of mutations increase only in African Americans. One important issue is you can imagine that if patients were exhibiting potentially an inferior outcome because of this, the genomic instability of the AML genome, but every time you analyze the potential for those mutations that are sitting in this subgroup, only in this subgroup, the potential for those mutations to alter or damage the protein integrity, they didn't achieve a threshold for damaging effect. It means they might be sitting potentially as a passenger. So it means potentially all this bad outcome is driven by genomic instability and not by a protein damaging effect of the mutation. So my student got an award from American Society of Hematology. I'm very proud of her. She's right now in New York, and I'm expecting her to continue this work. But let's try to summarize this. Genomic instability might be the major driver for poor outcome in patients African American diagnosed with acute myeloid leukemia. Once the genomic instability, meaning the number of chromosomic anomalies are accrued and they are very high, our data, even though it's a small data, suggests that the mutations that happen in those AML genome, they do not damage the protein integrity. So moving a little bit forward to the cell extrinsic effect that might be explaining clonal dominance and how clonal evolution happened from having a totally normal human genome to acquiring clonal hematopoiesis. Remember, clonal hematopoiesis being an allele frequency more than 2%, and then initiation of hemopoietic malignancies. Let's talk a little bit what might be happening in the AML ecosystem. So the sequencing knowns and unknowns, let's try to make the genome a little bit more practical. All right, let's talk about this patient that we saw about 2 weeks ago. He was admitted with 56,000 white cells. The hemoglobin was 17.6. As you can see here, the platelet count, it was 678,000. I'm going to put in red the factor that you are going to be facing. This is what we see in the clinic. This is what we see in the world. So I want to summarize with little boxes what is important. Number one, age in the very top. Number two, the past medical history. Never forget, we are clinicians. Smoking and the magnitude of smoking might be important for this. And this is the report that you will normally get from an NGS report. I want to walk you through this. This is a conference that is directed to our residents. We want them to like this. Okay, you can see here an AXSL1. Remember, this is a chip mutation, right? You can see what is the protein, right? The amino acid change in the mutation IDH1 amino acid chain as well, followed by allele frequency to the right. So this is the magnitude of potential cell harboring the mutation and the quantification of the mutation. Then you have COX. Remember, COX is a mutation that is involved in DNA repair. It's important, very important, because it can predict, like in our history of African Americans AML, potentially significant chromosomic abnormalities. Then you have a splicing event, you have a disease defining event, which is called JAK2. Remember, this is likely polycythemia vera. It's defined by this mutation. And then we are going to move very quick to the second report in the NGF report. Then you can start seeing some amazing features. Here you have the nucleotide chain, CT, and then you see GA, and then CA, and then you see again GA. So this is all information that is literally placed in the drawer. Everybody get a report, it get posted in the chart of the patient, and then it goes to the drawer. We wonder if we could use this in our favor. Then exogenous and endogenous mechanisms explain the initiation of mutations. The Sanger Institute in Cambridge have been working for a long time trying to determine if signatures or fingerprints of those exogenous and endogenous mechanisms might be sitting in the human genome. Let's talk about this. Let's say you're getting older. Then there are some mutagenesis. There is some mutagenicity mechanism like cytidine deaminase that normally lead to a very specific nucleotide chain, CT. Let's say the patient smoked and he developed lung cancer. All those mutations will develop CA. So we wonder if those signatures can be observed in AML as a whole. Is very well understood in solid tumor, but for hemopoietic malignancy, it hasn't been well documented. So you can see here, we already talked about the signature CT. It happens is a clock-like mutation. Once you achieve 60 years, then this mechanism for mutagenesis is activated. And you can see 6 more signatures. Again, this is all work from the Sanger Institute in Cambridge. Then the mutation accumulate with life, right? As we get older, more mutation happens, suggesting that clonal hematopoiesis might retain part of these genomic fingerprints. So recently we found this signature very well described CT and GA in breast cancer of patients who are older. You can see that how the frequency for CT and GA is in high proportion for breast cancer, especially elderly patients. CT, GA, oxidative stress, CT, I already mentioned, clock-like cytidine deaminase hyperactivity. Then we wonder, with our databases, here we have almost 300 patients. For every patient, every single line is a mutation. You can see how the numbers repeat and repeat and repeat. You're going to see 3, 4 mutations per patient. And then you have alignment for stressors, meaning age, you have smoking magnitude, etc., to this side. And here you have the nucleotide changes. It permitted to correlate and associate the density of the nucleotide changes with the stressor. Now we're looking for the potential reason what initiated those leukemia in our patient. Do you see it? It's very well done in solid tumor, but we want to apply the same principle to hematopoietic malignancies. Then let's read, since we knew those signatures, I'm talking about nucleotide changes, were present in AML, could susceptible genomic areas be eroded by putative stressor? Now we are talking about where the mutations are happening. The mutations are happening in exons, it can happen in introns, etc., etc. Can we aggregate all these mutations and subject them to the stressor, aging, smoking, etc.? Susceptibility genomic area will be a region with high propensity for mutagenesis. We want to understand whether or not this mutagenicity, this fingerprint, this signature might be sitting in our patient's AML genome. To do so, then we have a zooming. Remember, this is a genome viewer, and you can zoom in and you can zoom, you can zoom in and you can zoom out. And then you see here the little nucleotides and the substitution that we have been talking. Zooming in, zooming out, you can see how the aggregation of those mutations might happen. And then this is what we call a potential susceptibility region. Then let's suggest this susceptibility region to an stressor. This is part of the work that we did, and I don't want to go too quick, but in reality, to emphasize that all those mutations were aggregated by close proximity using cDNAs, right? The specific regions in the genome, in the genomic viewer, and then aggregation to create little hotspots, right? Further aggregation was achieved, as you can see here, by using the transcript that was used by that specific mutation. If they were using similar transcript, then we further aggregate until finding a susceptibility genomic region. Then let's subject that susceptibility genomic region to the potential stressor. We're going to start here with age. You can see a proportional increase in CA signature as the patient passed the median age of our population, 10 to 38%. For smoking, you can see here 13%, again, surpassing almost 40%. And then we aggregate elderly patients who are actively smoking. You can see the aggregation for that very important oxidative stress signature, GA, from 10% to more than 45%. So this suggests that those regions are affected and eroded by those important stress factors. Something is happening outside the cell that is creating a propensity and a fingerprint for those leukemias to be connected with smoking. Let's say if you have a mutation, CA, in lung cancer that is susceptible to immune checkpoint inhibitor, right, reactivation of the immune system, then potentially we might have the same principle in AML. Okay, let's try to summarize this. Single nucleotide substitution signature 8 seems prevalent in elderly patients with AML. Signature 8 is associated with oxidative stress and GA deposition in the AML genome. This is very easy to find. This is in every single report that we get in the clinic, in the works. It's described in breast cancer in our AML elderly cohort. Higher incidence of SBS 8 signature is observed among elderly patients with AML and prior tobacco exposure, suggesting a synergistic interaction. Okay, we're going to move, we're going to abandon the little domain of leukomogenesis and we're going to move into the therapeutic window. Remember, I'm not expecting you to remember all these mutations. It will be in the packet. You will look again, you will be reminded. But there were a few changes that recently the European Leukemia Network introduced to the classification and risk stratification of acute myelogenous leukemia, including modification in the perception of CPAP. It's a very good mutation. It should be monoallelic, biallelic, but it should be BSIP. And then FLIC3 is important because we have almost 5 medications that we incorporate into the treatment of chemotherapy as a targeted agent. It was moved from the adverse risk group to the intermediate risk, right? Independently of the allele frequency, this is mostly for the fellows. I always clarify this to my residents when they are in the leukemia unit. And then finally, we have a bunch of chip-like mutations that were incorporated into the risk classification. This is important because from the therapeutic window, we can incorporate part of these medications. You have the result of the AML trial incorporating gilteritinib, and you can see a significant improvement in the survival for patients when it's given as a single agent. Right to your right, you have the quantum R. This is quizartinib, and you can see again as a single agent a significant improvement in the survival of a disease that was historically connected with very poor outcome. Okay. Then let's move through a few conclusions. Individuals at risk for acute myeloid leukemia can be identified years, many years before, and it depends on the type of somatic mutation that can be collected from blood. The AML genome is a consequence of endogenous and exogenous mechanisms, right? Sometimes one, sometimes three mechanisms. Correct understanding of AML genome have permitted advance in the treatment of the disease. This is extremely important. Then what are the future directions and what is that I would like our residents to participate and be part of this enterprise adventure to create some avenue for treatment of AML. How to expand investigation of genomic factors that account for racial disparity outcome in AML, especially in African-American patients. This is a work that needs to be expanded. We have already a fellow working on this, and we have our student from Baylor already participating, investigating mechanisms that could prevent clonal expansion once chip is initiated. Remember, the AML ecosystem, the unmutated clone producing inflammation, how we are going to understand all this. So we're working on an IIT with dexamethasone, hoping that our observation that dexamethasone improved the event-free survival in AML patients might be reproducible in vivo in clinical trials. Investigate whether the mitigation of non-clonal inflammation could facilitate the clonal eradication. This is to emphasize the previous point. Investigate whether mitigation of oxidative stress, we need to understand a little bit better what is the mechanism, could improve the outcome of elderly patients diagnosed with AML. So the Milo Hub is our big project. You have the students that have participated in the creation of our 350 mutations database. Remember, this is a total of 280 patients from Baylor, but we are going to incorporate a large number from Georgetown. We are hoping to add Fox Chase and the NCI Mexico City to add a little bit more of the flavor for Hispanic and ethnic racial disparity. So this is going to be a big project. We're working on a centralized IRB. Very soon we will have news from this for everybody. With that being said, thank you very much and open to questions.